hospital doors. The difference between life and death often comes down to seconds and to whether the right infrastructure is in place. Our next discussion is all about revolutionizing emergency medicine infrastructure. And to moderate the session, please welcome back Ekta Batra, requesting Dr. Sanjeev Bhoi, Professor of Emergency Medicine at AIIMS Delhi, Director of the WHO Collaborating Center for Emergency and Trauma, who joins us.
Thank you, Doctor, for joining in. So, emergency medicine at AIIMS Delhi must be a very busy place for you. Tell us about your experience as a trauma doctor, as an emergency doctor. Is it exactly like the shows we watch? Is it as dramatic? And where do you think we're lacking?
It is really exciting. First of all, I thank CNN 18 to give opportunity to first time speak about emergency care and how has there been journey from casualty to emergency medicine, the right way I'll put it. So the experience is, it was way back in 2002 when there was a parliament attack, and you know that all the top wigs of the country, they come to AIIMS. So immediately, and the old casualty, they usually manned by the junior most doctors, taking care of the sickest patient. Sneezing to cardiac arrest, it comes in emergency. So post-parliament attack, the government thought that we had to put specialists in the emergency room, so-called erstwhile casualty. A medicine doctor, then anesthesiologist, one few orthopedicians, and medicine. That was from me. Put together in that casualty. And then the game changed. Then we thought that this is a place where you get sickest of most patients and untrained or less trained doctors, nurses and paramedics are there. And you have to perform in very time critical fashion for the patient to become well. And that was the journey, trajectory in developing a casualty to academic emergency medicine, which took almost, before me, 2002, there were also efforts in developing emergency medicine. So in 2012, we got the academic emergency medicine department at AIIMS. And like you said, that what is emergency care? What is the definition of emergency care? Is anything you feel is emergency medicine. Because the patient emergency is the most important thing a physician has to think of when it comes to the emergency. Yes, you get a sick patient, a patient who is coming with chest pain, somebody is coming with trauma, somebody is coming with bleeding everywhere, somebody is coming with a snake bite, somebody is coming with a scorpion bite, somebody is coming only with, fever, mild fever. Or somebody is coming and shouting at you, get me a medical exam done immediately. So, and then you have to manage, 360-degree approach in short time. So in all 5 minutes of all emergencies is emergency medicine.
Okay. India, however, lacks ICU beds at this point. There is a dearth in terms of the ICU beds, and it's not given as much importance. As the earlier doctor had mentioned, we don't even, they have OTs in the trauma care. Many hospitals don't. How important is the infrastructure for ICU, and how much does it lack in the country right now?
So I'll take this question in the concept what is called as the ECO model: emergency, critical care, and operative care. So when a patient comes with emergency, suppose for example a trauma or a pain abdomen, perforated abdomen, you require immediate frontline will be a system. You require a system, not only beds. So the system will save the patient, not the beds actually. So you require a person that you have to recognize a sick condition. You yourself should say, I should seek care. Go to the doctor. Number one. So number two, you have a strong emergency medical response system to take him, or ambulance system to take him to the right hospital. When you come to the emergency room, you have the trained human resource should be there, to take care of the patient, when preventing him from any arresting or dying. Then the surgeon comes and takes him to the OT, or the patient after OT goes to the ICU. So the whole chain, and after the ICU, he goes back to the community. So the whole chain is called as emergency care system, which are all components are there. One of the important components you talked about the critical care beds or ICU beds. So if you see the data which we have, which we did a study, maybe I think that is a study we did, the AIMS Niti Aayog study. So what we felt was there was lack of, you have almost 30% of your patients, in a hospital, they are actually with emergency condition they come. And they have only, they had only 10% of beds, against the 30% of load. And you can see the proportion of critical care beds we have. There is a dirt need, for upgrading, upscaling the critical care beds. And let me tell you that there is an initiative. This is called ECO model. The government has taken AIMS and the Niti Aayog and Ministry of Health and all the academia. They've taken a strong decision to create that infrastructure across the country. If you see the PM Abhim Yojana, which is, it is for what is called a critical care blocks are coming across the country. That will help in addressing the critical care beds across the country. And in district hospitals also, there will be ICUs have been, are being upgraded to ICUs. But the main problem here is, the manpower. Correct. The manpower are being trained in both emergency care and critical care. That will also help to solve the issue.
You were a part of the AIMS Niti Aayog gap analysis where you looked at 100 facilities. You've spoken about how ICU beds, there is a dearth. But what is the one biggest system failure that India is facing when it comes to ICU care?
See, ICU care should not be taken.
Emergency.
Yeah, emergency, because it is acute. You can say compendium of acute care. So the main findings we got was our lack of trained human resource, which is actually the main problem. One of the main problems is trained human. Second is lack of process engineering. Process engineering is the problem. I'll give you just an example. If you have everything under the sun and still the system is not working or saving the patient, that means there is a lack of processes. So what we found in nutshell, if I say, lack of trained human resource, there was good infrastructure in many places, lack of processes were there. So if I have to, address this, I'll work in creating an emergency care system, not systems in silos. Second will be work on improving the processes, so that whether you like it is just like having a McDonald's in Arunachal, McDonald's in Delhi, so that you get the same burger. Emergency care is same. You should get the same care in Delhi and in Arunachal. So that is the model, and these are all the steps. You can do it and it can be achievable, and it's being done right now.
So it's standardization of care across the country.
Yes.
But at the end of the day, do you think that would fill the gap when it comes to rural, district level hospitals vis-a-vis tier 1 urban city centers?
Yeah, very good question. Is the study also focused on 50 hospitals or district hospitals. Let me tell you, if you see, in the study it will be really amazing. Also, district hospital performed better than medical colleges in some of the indicators. So, yes, the question is strengthening emergency care in primary care is a big issue, and it should be addressed. And there is almost, because 70% population goes to the district hospital. So in a mission mode also, they are being upgraded, many of them, to medical colleges. Number two, there is another research project going on to improve emergency and trauma care and burns care in district hospital levels. So this is being done by creating standards. So during COVID, because a lot of resource mobilization has also happened, it is improving, so suddenly improvement in equipment and supplies. The HR being skilled by various training programs for training. Third, working on process engineering, creating separate programs like AIMS Delhi now we are mentoring 7 states of India to create systems. System saves life. Individual will not save life. Individual brilliance doesn't save life. Creating beds doesn't save life. So we are training the team in system building. We're calling it champions of change. So we have covered Maharashtra, Madhya Pradesh, Tamil Nadu, Kerala, Arunachal Pradesh, UP, Leh Ladakh. So we have given a few examples, I am telling you, that we have worked on system building and is showing fruits at the grassroots, like district hospital and below.
Okay. Well, Doctor, I'm going to wrap up this session by asking you for an example. If you could share a real-life example from your experiences when it comes to a successful trauma care case, and maybe something, a leaflet out of, all of your experiences which stands out to you, maybe as a good or a bad example.
So, the best trauma case I like to give it from AIMS Trauma Center, where we had a patient where actually he had a impaled object, which went through and through from the chest, abdomen, and through. So it came in, media highlight, few years back, some 10, 15 years back. The patient was, and he was stuck in a car. The gas scatter was, brought from the Delhi metro. We had to cut the car in front of the emergency department of trauma center, take the patient there, and the patient, difficult to resuscitate because the patient did not lie down because a huge rod was there, through and through. And the difficult intubation means airway management. The patient, went to the OT in no time because the system is such in place that it goes from emergency to OT within 5 minutes of arrival. That is how well-oiled system was. And all, like Dr. Dubasi said, the trauma team jumped in, you have in place, went to the OT, did a successful OR, and he went back home alive, and he is now living in Australia.
Oh, wow.
So that is an example of a system which works.
That is excellent. Thank you. Thank you very much, Doctor, for joining in and giving us, what we need to do in terms of improvement of trauma care and what stands out.
Do you know what will happen if you read one book every week? Let me share some 3 powerful benefits.
Is standardization of operations. So you just follow the protocol and you'll reach where you have to.
Just one message I'd like to give.
Sure.
That this is the first time the advocacy of the media platform like this for a stronger integrated emergency trauma services in the country in a mission board is a strong partner is media advocacy. And so we thank you for inviting us also. And very important is which is going to be launched by nationally, there will be what is called a school CPR program across the country.
That is a must.
Yeah, school CPR project. It has been there. Studies have been done. Now the NITI Aayog is going to roll it out across the country, school CPR program.
Okay, thank you. Thank you very much, Doctor, for joining in and speaking with us.